Hi, you guys. It's Dr. Baker Townsend. I want to talk to you about uterine involution. So uterine involution is during the fourth stage of labor where the uterus contracts down and closes the open arterioles that are trying to perfuse the intervillous gap with oxygen and nutrients. So let's just review real quick. Stage one, the first stage of labor, is the process of cervical dilation. So you guys, remember, labor is when your cervix, when you go into labor, how we know you're in labor is your cervix will continue to efface and dilate. So doesn't matter the number of contractions. We know that contractions every 3 to 5 minutes is a characteristic of labor, but it does not mean you are in labor. So the first stage of labor is cervical dilation. That's made up of 3 phases. The first stage has 3 phases. The first phase is early, 0 to 3 centimeters. Active, 4 to 7 centimeters. In transition is 8 to 10 centimeters. That's the stage 1. Now I just want to show you on the slide about the uterine ligaments. Remember the broad ligament, the round ligament is this big ligament that goes over top of the uterus and anchors the uterus in your body. And then the round ligament are these little ones on the side. And this is what's responsible for this lower pelvic pain. These things get really stretched out during pregnancy. They're like rubber bands. They stretch, and hold the uterus in place. Stage 2 is when your cervix is completely dilated and you're pushing and you have the baby. So it begins with the cervical dilation 10, effacement 100, and pushing, and it ends with delivery of the baby. Stage 3 begins after the baby is delivered, and it is concluded with delivery of the placenta. Now, you guys, this is very dangerous because we know those arterioles are blown open, trying to perfuse that uterus with that extra blood volume. And so we need this placenta to deliver so that this uterus can contract down and prevent mother from bleeding to death. Usually, you guys, stage 3 labor lasts less than 20 minutes. If it's more than 20 minutes, we know we have a problem. The uterus could have, it's called an accreta, could have gone past the decidua if there was scar tissue there, and implanted in the uterine muscle. So we have to get it out so mother doesn't bleed to death. Here's just a little schematic of the fourth stage of labor. So remember, you guys, the placenta now has delivered. These arterioles where the placenta set are blown open and she's bleeding from here. We have the decidua all along the lining here, which will shut off in the first 3 to 5 days. But what we're really concerned about is right here at the placental site where the arterioles are open and the decidua is gone, and mom can hemorrhage from this site. So you guys, the big decrease, once the placenta is delivered, there's a huge decrease in estrogen and progesterone. That triggers an oxytocin bolus, and we know that oxytocin causes contractions. So we're very excited about all the parts of the placenta getting out. We want it to deliver in whole, but if it doesn't deliver in whole and there's little remnants in there, you will not get the full oxytocin bolus that you needed to completely compress your uterus, so you'll have heavier bleeding. That's one of the signs that we know there could be retained placental fragments. The reason why we have retained placental fragments is because our placenta was not in good condition. Either it was old after 42 weeks, it had damage, from, as we know, smoking, drugs, any endocrine or vascular abnormality, hypertension, thyroid problems, hypertension, diabetes, any of those things. So you guys, we get that big oxytocin bolus so that it will contract your uterus. Also, oxytocin is the hormone of love. So if you have a marginal looking baby, you will still think it's the best looking baby ever. This is why you fall in love with your spouse, from those oxytocin boluses. Just want to show you, I'm going to switch over here to paint real quick. I just want to show you I want to show you the ligament. So you can see here on the side where that ligament was stretched initially. And when the uterus involutes down, those ligaments are no longer tight and stretched because now the uterus is compressed. Now those ligaments are really loose. So the round and the broad ligaments are like loose rubber bands, which is not good. So in order to prevent ourselves from pushing the uterus out because those ligaments are loose, we use the two-handed approach to assess for uterine tone. We put that one hand right above the pubic bone and the other hand at the umbilicus, and we feel for uterine firmness. Of course, we want this uterus to be firm. That means it's contracted. If it is soft, that means it's not contracted and it's bleeding. So the first intervention we would do is a uterine massage. You just go in a clockwise fashion with this top hand and gently massage this uterus, and it will help the tone. It will cause a contraction and stop the bleeding. So one problem that we do have, however, is the bladder. The bladder, you need to make sure that thing is empty because the bladder and the uterus are besties. They sit right next to each other in the pelvis. And you guys, we give moms a ton of fluid during labor. And she also, once she loses the placenta, it tells her body she's no longer pregnant. It triggers a massive diuresis, which can cause this bladder to fill rapidly. If this bladder fills, and by the way, mom's bladder is stunned from all of those contractions during labor. So mom neurologically sometimes does not feel the urgency to void or the need to void for 24 hours, even if her bladder is overfilled over 1,000 milliliters of urine. So you guys, it's a big thing nursing wise that we have to keep an eye on this. So you guys, if this bladder overfills, and you can see that right here, it will cause this uterus to go up and soften because it has no room to contract down because the bladder is filling the space. So very important for you to palpate the bladder and make sure the bladder is empty. Assist her to the bathroom if she's had an epidural. Make sure that you cath her to get fluid out of the bladder so the uterus has a place to sit and contract down, that the bladder does not occupy that space. Do you want to talk about these pelvic floor muscles? Again, I know I talk about these quite often, but it's really important. These pelvic floor muscles, so if you don't do Kegel exercises and there is 15 pounds worth of content of the uterus, meaning the actual hypertrophy of the uterine muscle, the amniotic fluid, the baby, and the placenta, which is 15 to 20 pounds, that bowling ball sitting on this pelvic floor makes it atrophy. So you guys, you tell them to start Kegels before they get pregnant, and then every day that they do them, they're lifting a little bit more weight. It's like weight training, and so that will preserve this pelvic floor. Very, very important. So you want to monitor for blood loss. Normal vaginal birth is less than 500 milliliters estimated blood loss, and a C-section is less than 1,000. A hemorrhage, I'm going to scoot this over for you. A hemorrhage is greater than 500 EBL for a vaginal delivery and greater than 1,000 for a C-section. So so you guys will know this, the provider, the midwife, or the physician will tell us what the EBL is. But if they're gone and now you have a patient who you feel like she's bleeding heavy, if she saturates a peri-pad in 15 minutes, that constitutes a hemorrhage. That means there's a hemorrhage. And so I just want to let you look at the blood loss. So bleeding, normal bleeding is all of this. Scant, a 1-inch stain. This is in an hour. Light, 1 to 4 inch stain in an hour. Moderate, 4 to 6 inch stain in an hour. And then heavy bleeding is saturating a complete peri-pad in an hour. This is where we really start to get concerned. So you guys, when you see a saturated peri-pad, take it off, sit the patient up in high Fowlers, clean her up, put a peri-pad on so that the blood drains to the peri pad and not behind her. That's why I want you to sit her up and clean her up really well. And then check that peri pad in 15 minutes and do a uterine assessment for tone. If you have saturation of the pad in 15 minutes, we know it's a clinical hemorrhage. If the uterus is soft, we know that she's bleeding inside, that the uterus is not contracted and compressing those veins and arterioles. We know that we have a hemorrhage situation. We'll talk more about hemorrhage later, but I just needed you to see what was normal and what was abnormal with uterine involution. Thank you and have a good day. Oh, of course, I'll post this on the discussion board if you have any questions or concerns.